lot of things have changed in glomerulonephritis in the last few years, last 5-10 years. Most important is there is a molecular paradigm change that has occurred in glomerulonephritis. All of you should understand this molecular shift. Most important part of the change is moving from a descriptive histology to targeted immunopathogenesis in modern renal pathology. Earlier, when we were students or when we were teaching your previous batches 10-15 years, we were talking about descriptive histology. As far as glomerulonephritis is concerned, what are the histological patterns? Now that has changed totally to what is called the immunopathogenic this. So the nephrotic spectrum, as you can see here, come here this side. So clinical presentation and structural reality. So we have the nephrotic spectrum, and this nephrotic spectrum has got nephritic and nephrotic. Nephrotic means heavy proteinuria, edema, the nephrotic syndrome type of picture. Whereas nephritic is hematuria, hypertension, sediment. First fundamental distinction is, does he have only proteinuria or does he have cellular elements also in the urine, like hematuria, hypertension, and active sediment? If that is there, then we are in the nephritic and compared to the nephrotic picture. So earlier there are two aspects of the disease are, one is glomerulopathy, the other is glomerulonephritis. Glomerulopathy is a structural functional abnormalities like podocytopathies, minimal change disease, or focal glomerular sclerosis, segmental glomerular sclerosis, which we have seen in the nephrotic syndrome, FSGS, MCD, and podocyte. Whereas in glomerulonephritis, true proliferative and inflammatory injury is there because of the inflammation driven by the resident cell proliferation and or leukocyte infiltration. So you have to, in your mind, clearly look at, am I looking at a glomerulopathy? Am I looking at a glomerulonephritis? The difference is glomerulopathy is minimal change disease, podocytopathy, focal segmental glomerular sclerosis, heavy proteinuria. Whereas when you are looking at glomerulonephritis, true proliferative and inflammatory injury is there in the glomerulus, and that produces resident cell proliferation and leukocyte infiltration. So from now onwards, you can see on the screen. You can see there also, because you are not stuck with this laptop anymore. So, okay, one more slide is here. Okay, immunofluorescence. So how do I now go about? I have to do not only histology, do an immunofluorescence stain. If the immunofluorescence today dictates the pathogenesis, replacing the descriptive light microscopy pattern. Why I need to know all this? Because my treatment is dependent upon the immunofluorescent type. Okay? One is called the Ig dominant, immunoglobulin dominant. Second one is called the passive immune response. There is almost no immunology involved here. In the Ig dominant, immune complex glomerulonephritis is the picture. It is called immune complex glomerulonephritis. Infection, autoimmune diseases, and idiopathic are the cause. When you have passive immune or negative for immunofluorescence, you submit for the immunofluorescence. He gives very few staining immunofluorescence stain or no immunofluorescence stain. Then this is ANCA-associated glomerulonephritis, which is lupus type of nephritis. ANCA-associated glomerulonephritis. The third one is linear Ig, where anti-GA, GBM glomerulonephritis will be there. If you say linear type of immunoglobulin, then it is anti-GBM and monoclonal gamma. What is monoclonal? In gamma globulins, how many types are there? There are different types of gamma globulins are there. If only one particular type of chain is affected, it is called monoclonal gamma. So monoclonal gammopathy, immunoglobulin glomerulonephritis. And finally, C3 dominant type, complement 3 dominant type, where C3 Ig is 2 times more than the other immunoglobulins. That is called C3 glomerulopathy. What is the difference between previous era and now? Now we are not basing on the histology. We are basing on immunofluorescence. Immunofluorescence stain must be obtained in all specimens of glomerulonephritis. And what are the 5 types? Ig dominant, which is whether this just check whether no, it doesn't go. That's not the type of pill. That's not the pill. Set up. You also set up. Okay. The first type is the Ig dominant. Second one is the pauci-immune type. And the third one is the linear Ig. Fourth one is the monoclonal gammopathy. Fifth one is the complement mediated. Now, these slides are this. So you can see here in this slide very clearly that is the podocyte there and the food processes are there in the foot. You can see here food processes and in the foot, not on the slide here. It is there. Yeah, you can see that. Okay, these are the various types here. So, infection-related glomerulonephropathy. What is the thing, infection-related? You have got the innate adaptive host defense with or without molecular mimicry. Pathogen identification, infection control, antibiotics will have a role. This is infection-related. The second one is the autoimmune glomerulopathy, and third one is called the alloimmune. What is alloimmune? You give a transplant, and the transplant kidney gets infection is called alloimmunity. Autoimmunity, your own antigens producing immunity. Alloimmunity, same species. Another kidney is given and that gets glomerulonephritis. Adaptive immune response to donor antigens, which is a transplant kidney. And autoinflammatory glomerulonephritis, inborn errors of innate maturity, alternative pathway dysregulation, monoclonal gammopathy related things. Depending on the pathogenesis, there are the 5 types: immune-related, autoimmune, alloimmune, autoinflammatory, and monoclonal gammopathy. As I told you now, the infection-related glomerulonephritis, Ig dominant, pauci-immune, linear Ig, monoclonal Ig, C3 dominant. Why I need to differentiate? The treatment is different. Okay, now you see this is the electron microscopic stimulation of a photograph of a podocyte. So you can see the food processors and the podocyte. There are what is called the phospholipid and antigen 2, that is PLA2 or podocyte food process antigen, THSD7, another slit diaphragm antigen, and new targets are there, NEL1 and Exit1 and TXT2 and SEMA3B. There are various types of antigens related to the food process. Membranous nephropathy is no longer just a pattern of injury, but it is an autoimmune disease targeting specific endogenous podocyte antigens. What are podocyte antigens? PL2A, PLA2 or and then THSD7 or D7A and then NEL type of antigens. Okay, now what was the old paradigm? The old paradigm is primary versus secondary. We used to talk as primary glomerulonephritis, where no cause could be found. Secondary to SLE, secondary to graft, secondary to streptococcal antigen, some sort of secondary cause we used to say. Diagnosis relied heavily on the renal biopsy to see the histological pattern. Now, this classification was based on clinical history, idiopathic versus secondary. Now, monitoring, waiting for clinical remission and proteinuria to drop. This was a previous paradigm. What is the newer paradigm? diagnosis, serum markers are important. Anti-PLA2R antibodies can often diagnose without biopsy. Classification is strictly by the molecular target depending on which antigen is involved. Monitoring is immunological remission, not proteinuria remission. Okay. So previous one, aberrant galactose deficient IgA1. GD is galactose deficient IgA1 production, autoantibody creation, immune complex deposition, inflammatory injury. This is what we used to think. Now, the linear model fails because there is what is called a multi-hit hypothesis, multi-hit mechanism explaining the initial cascade but fails to capture the chronic relapsing remitting type of relapsing and remitting IgA, does not account for the cumulative nephron loss that continues even during apparent clinical remission. Because old one does not tell you about the nephron loss. It only looks at the clinical remission. IgA is not a single cascade. It is a self-amplifying cycle. Now, what is the amplification? Start with mucosal immune dysregulation. That means environmental triggers are there, microbiota are there, pathogenic galactose deficient immunoglobulin A1 and immune complex formation, that alternative lectin component activation in the mesangium, glomerular inflammation, DAMP release, and HMGB1 release also. Irreversible fibrosis and nephron. This is a cascade. Mucosal immune dysregulation, pathogenic IgA1, then alternative or lectin component, then glomerular inflammation, finally irreversible fibrosis. This leads to tissue damage, which triggers further autoimmune response via the molecular mimicry and TLR signaling. Now, what is the therapeutic takeaway? Now, I have APRIL BAFF inhibitors and complement inhibitors and must interrupt both the upstream immune drives and downstream fibrotic cycles. We have immunotherapy which will have a bearing on the treatment depending on the pathology. Now look at that. The first one is in the neutrophil is there in the vasculature. A trigger inflammatory cytokines are produced that primes the circulating neutrophil, causing the translocation of intracellular antigens. The neutrophil, there are antigens, the purple ones and the blue ones. They are the MPO and the BR3 antigens. They are released into the circulation. And these antigens attract the antibodies, they are the Y-shaped ones. They will have an antigen-antibody complex on the surface of the neutrophil. Binding and activation takes place. Circulating ANCA binds to the exposed MPO and PR3 in the neutrophil surface, causing massive activation and degranulation of the neutrophils. Neutrophil granules are thrown out into the circulation. That is the trap, and necrosis highly pressurized glomerular capillary forces and activated neutrophils to release the neutrophil extracellular traps, that is called the NET, causing direct endothelial necrosis and crescent formation, which is called the pauci-immune glomerulonephritis. This is ANCA-associated vasculitis. We already told 5 types. What is the first type? Yeah, that is the IgA nephropathy. The first type is the IgA nephropathy. The second one is what we are seeing is the ANCA nephropathy. Here, not much of immunoglobulins are there. It is only damage through the granules of the neutrophils. Why? Via the neutrophil antigen. That is the second type. This is ANCA-associated neutrophil trap. This is called the NET, neutrophil extracellular trap, and pauci-immune glomerulonephritis. Then you have got the AAV, the C5 amplifier loop. There is a C5 receptor in the glomerular basement membrane, and C5a anti-receptor will be attracted by the C5a complement 5a, and complement activation generates anaphylatoxin. C5a binds to C5a1 receptor, massively amplifies the neutrophil recruitment, trafficking, activation in the intravascular bed, fueling the necrotizing vasculitis. So there is a therapeutic shift Why? Avacopon is the treatment which will inhibit the C5A receptor inhibitor. Now we have a specific drug which inhibits the C5A receptors and it is called avacopon. This is the AAV type or C5 amplifier loop type. Now you have got the MPGN, that is membranous proliferative glomerulonephritis, deconstricting that. There are two types in MPGN. One is IgA positive, the other is the IgA negative. In the IgA positive, C3 complement is almost absent. In the IgA and IgG negative, C3 is the dominant one. The first one is IgG positive. Immune complexes are mediated by infection, autoimmune and monoclonal. When C3 is dominant, alternate pathway dysregulation is there. This is called C3 glomerulopathy. What was earlier called as MPGN is now two types. One is the IgG positive immune complex type. The other is the C3 dominant type or IgG negative type, which is called the C3 glomerulopathy. The MPGN label is now obsolete. We don't call it as MPGN. We will call it as immune complex mediated IgG positive or C3 dominant IgG negative alternate pathway type. These are now two types separate. Now, U3, C3 glomerulopathy, precision cluster analysis, fluid phase activation, cluster 1 and cluster 4, massive alternate pathway activation, circulating in the fluid phase. Biomarkers are low serum C3. How do I diagnose? C3 is consumed, so low serum C3 levels will be there. High prevalence of genetic and acquired alternative pathways. Dense intramembranous and subendothelial deposits will be seen. The takeaway from this slide is advanced clustering mouses past even the C3G into personalized risk assessment for the end-stage renal disease. So everybody requires to be investigated for C3 glomerulopathy also. Now finally, you have got the matrix. What is the matrix here? Glomerulonephritis EAC matrix, a complete language for glomerulonephritis. At the base, what we have got? The pathogenic types. What are the 5 pathogenic types? Infection type, autoimmune type, alloimmune type, autoinflammatory type, and monoclonal type. This dictates what drugs to use depending on what is the pathogen. Second one, about the activity. Immunological activity, acute inflammation dictates immunofluorescence. We should use immunosuppressants right now. If there is an activity, the treatment is immunosuppression. If there is no activity, don't expose the patient to immunosuppression. And finally, in the chronicity, irreversible scarring and fibrosis, and it needs to be cardiorenoprotective treatment. Dictates the cardiorenoprotective CKD care over the immunotherapy. Now, pathologically, I must try to distinguish the 5 types. Infection-related, very heavy immunoglobulins will be there. Autoimmune type, where the positive immune type, alloimmune type, transplant fellow, autoinflammatory type, and then the monoclonal type, only one type of globulin is enriched. Once you come to the activity, we have to see the immunofluorescence and decide on the activity of the disease. Depending on whether we give immunosuppression or not, we will decide. And also, the chronicity is also important. Now, activity versus chronicity in clinical action, applying the 2024 guidelines. How do I know whether it is active or chronic? Active indices are endocapillary hypercellularity, leukocyte infiltration, cellular crescent, fibrinoid necrosis, aggressive targeted immunosuppression must be given. When you see this type of pathological picture, endocapillary hyperreactivity, hypercellularity, leukocyte infiltration, cellular crescent, fibrinoid necrosis, this person requires aggressive targeted therapy, immunotherapy. Whereas chronic patients, irreversible, glomerular sclerosis, fibrotic crescents, tubular atrophy, interstitial fibrosis. Here, we don't have to give immunosuppression. Reduce the immunosuppression and bank on ROS inhibitors, SGLT inhibitors, and CKD management. Here is a case where the clinician should know whether he should use immunosuppressive medication or de-escalate the immunosuppressive and concentrate on the renoprotective medication. The absolute necessity of scoring both activity and chronicity is to prevent over-immunosuppression of a globally sclerosed kidney. If the kidney is already fibrosed, sclerosed, there is an active inflammation there, there's no point in giving the immunosuppression. Versus another person where there is active immunological injury is going on, you require the immunosuppression. Now look at the 4 various parameters. One is the clinical parameter, macroscopic slate, that is the patient presents with nephritic or nephrotic symptom, depending on the proteinuria. Macroscopic slate blue, that means whether he has only proteinuria, heavy proteinuria, or he has got associated with that cellular elements also are there, that decides whether it is nephritic or not. The second one is renal biopsy, performed immunofluorescence, prioritized over light microscopy to place the patient in the 5 different categories. So you do an immunofluorescence, and as we have said, Ig dominant type, C3 dominant type, passive immune type, whatever is the type. Then the molecular matrix. Now we wanted to know whether the disease is finalized by deciding its exact antigen and molecular drivers. Which antigens are involved, PLA2 are involved, or C5a is involved, or C3 is involved. We have to find. Finally, highly personalize and target the specific chemotherapy from descriptive histology to precision nephrology treatment. Until then is pathogenesis and what we have understood. Now, we are now moving into the clinical diagnosis. Glomerulonephritis, clinical presentations and diagnostic workup. Moving from a histological pattern to precision immunophenotyping and advanced synthesis of the KDIGO guidelines we can see here. Now you see, the bottom is the clinical macro lens. What are the patient signs? Is the edematous? Is there proteinuria? Is there hypoalbuminemia? What are the symptoms? Clinical context, is there any evidence of infection, autoimmune disease, or extrarenal manifestation, or transplant history? That is the macro level. Then come to the biochemical level. Impaired excretory function, proteinuria qualification, and estimated EGF. In the third level is serological and immunotyping. Here detectional specific, autoantibodies, alloantibodies, complement profile, and free light chains. And finally, the tissue level, here we have got ultimate classifier, light microscopy, immunofluorescence, electron microscopy, when waivers do not apply. That is the fourth level. Okay, we are transgressing from nephritic spectrum to nephrotic spectrum. What is nephritic? Inflammation and acute sediment. Dysmorphic RBC are there in the urine. RBC casts are there. Hypertension is there. Acute kidney injury. Whereas in the nephrotic spectrum, severe barrier dysfunction, proteinuria more than 3.5 grams, hypoalbuminuria, and edema is there. This is the nephrotic syndrome type. Nephritic and nephrotic. Rapidly progressive RPG and glomerulonephritis, we have to identify. Now, the slow burn glomerulonephritis elderly patient, asymptomatic early immunoglobulin G immunoglobulin A glomerulonephritis. These are 2 classical presentations. One is the elderly patient, often presence of CKD, minor urinary abnormalities, isolated normal GFR. Active vasculitic lesions may be subtle or absent. Despite low initial GFR, these patients are often highly responsive to combination therapy, though a high risk for treatment toxicity. The other type is asymptomatic early IgA nephritis. Most common primary glomerulonephritis worldwide, frequently slow in progress, asymptomatic for decades. Patients may only exhibit incidental microscopic hematuria, low-grade proteinuria, but possess circulating galactose deficient immunoglobulin A. This is called GD immunoglobulin A1 as the bio. Now, look at the standard assessment. What do I do? CKD, EPI, creatinine equation. Earlier we used to use the creatinine and put it in the EGFR using the MDRD equation or the CF equation. Now, there is another methodology called the EPI creatinine equation, which is preferred to convert the creatinine into EGFR, or modified Schwarz equation is also preferred. Full age spectrum equation may be also utilized. Now, the nephrotic pitfall is in the presence of nephritic syndrome and severe hypoalbuminemia, tubular creatinine handling is fundamentally altered. Consequence is creatinine-based formulas are erroneous. What we were doing? We were using creatinine and converting creatinine into EGFR using MDRD equation or Crockfield-Gauss equation, CF equation. Now, what are we doing? This is obsolete now because creatinine-based formulas can overestimate the GFR and give you an unnecessary safety. Now, what I have to do? Consider cystatin C-based equations. What are those equations? CKD, EPI, and then the modified Schwarz equation. Now, proteinuria assessment. 24-hour collection, spot collection. 24-hour collection, the process, it averages variations from the circadian rhythm. Physical activity is also taken care of. Posture is taken care of. Preferred for exact quantification of glomerulonephritis. The problem is highly subject to patient errors in the collection. 24-hour collection, some people may vomit, some voiding, some people may collect this morning as well as next morning also. Some collection errors will be there. Versus a spot creatinine ratio is very easy, very practical, convenient, avoids collection errors. First morning void urine is asked. The problem is it underestimates the 24-hour expression. Guideline target in pediatric, a protein creatinine ratio of less than 200 milligrams or less than 8 milligrams per hour in a 24-hour urine is the universal goal across etiology. You must target to bring the proteinuria to that level. Okay. Now, the paradigm shift in the glomerulonephritis. So, what are the 5 types? Infection-related, autoimmune, alloimmune, autoinflammatory, monoclonal gammopathy. Earlier, we were depending on the microscope, histology-focused, light microscope. Now, glomerulonephritis is primarily an immune-mediated disorder originating outside the kidney. Where is the immune injury occurring? It is outside the kidney. Kidney is only an incidental organ which is affected by the systemic immunological problem. There is in the blood itself, there is a systemic immunological problem, either infection-related or autoimmune glomerulonephritis or alloimmune or inflammatory or monoclonal gammopathy. The war is occurring in the system. What is happening? The effect is seen on the kidney, on the filter. Okay, glomerulonephritis is primarily an immune disorder originating outside the kidney. Histology shows the damage, but serology reveals the cause. Earlier, we were thinking only about histology. Now we have changed on to serology-driven, immunoglobulin-driven diagnosis based on the immunofluorescence and markers. Now, what are the serological typing sites? So I get a patient of glomerulonephritis. I don't stop with light microscopy. Ask for immunofluorescence and also look for the serology. What serology? I have to ask. Anti-PLA2R M-type phospholipidase A2 receptor. This PLA is phospholipid. Phospholipid A2 receptor, that is the biomarker. What does it tell me? It tells me about the membranous nephropathy, primary membranous nephropathy. Ig4 subclass antibodies attack the 185 kilodalton transmembrane glycoprotein on the podocyte food processes. Now, clinical utility, high titers are indicated, lower likelihood of spontaneous remission. Drop in titers proceeds, clinical remission. The second one is the ANCA, which is the PR3 and MPO. What are these? PR3 and MPO are neutrophil antigens. These neutrophil antigens are released into the circulation, and that is the one which is producing the ANCA-associated vasculitis. That's why this is called post-immune glomerulonephritis. Non-sclerosing glomerulonephritis. Antibodies target neutrophil granular protein triggering inflammatory vascular damage, can trigger immediate immunosuppression without waiting for the biopsy. That means what? In ANCA, you don't even wait for the biopsy. If you find the PR3M2 antigens positive, it is a passive immune glomerulonephritis, immediately you should go for immunosuppression. Anti-GBM disease, where it's a good pastor's disease, mechanism not defined, medical emergency, a positive serology for good pasture mandates urgent plasma exchange. Okay, this is the imperative in the treatment. Now, biopsy adequacy rule. A standard sample requires 8 to 10 glomeruli to confidently diagnose or exclude the focal segmental lesion. Light microscopy, architecture, cellularity, activity, crescents, necrosis versus chronicity like sclerosis, fibrosis. Stains used are para-amino acid shift stain, hematoxylin and eosin stain, trichrome stain, and John-Sellers. Whereas when you do immunofluorescence, pathogenesis and immune reactants, IgG, IgA, IgM, C3, C4, C1q, kappa and lambda light chains, all are now targeted because of the immunofluorescence. If you do the electron microscopy, exact location of the immune deposit, you can pinpoint whether it is on the photocyte food process or on the GBM, where exactly it is there. Now, MPGN reclassification, histology and molecular typing. Old paradigm, MPGN, a catch-all light microscopy pattern, endocapillary proliferation, capillary wall thickness. You call it MPGN. Minimally proliferative glomerulonephritis. Now you have subjected that person to immunofluorescence. Then to two groups, immune complex mediated, complement mediated. Immune complex mediated polyclonal immunoglobulins point to infection, autoimmune, lupus, monoclonal source. Complement mediated, predominantly C3 complement deposit point to alternate pathway dysregulation. Now, criteria for when do I don't require a biopsy? Though the risks of biopsy outweigh the diagnostic certainty and the serology is the serology definitive? If the serology is definitive, these are the following biopsy waivers. If the serology is not definitive, then you have to do the biopsy. What are the serologies? PLA2 antibodies and MN antibodies, or AAV, MPO and PR3 antibodies from the RBC they are coming. So especially in rapidly deteriorating patients. Anti-GBM disease, urgent plasma exchange because of good posture. Genetics and systemic, Alport's disease, Fabry's disease, well-characterized familial focal sclerosing glomerulonephritis, and other types of fasciitis. I used to have one patient of Alport's syndrome, and finally he died. He had this nephritic type of nephrosis, a genetic syndrome, Alport's. Now, you see, exception handling in PLA2 and primary membranous nephropathy. What I have to do? Measure PLA2, phospholipid antigen 2 receptor, a positive test. What I have to do? Do the test, primary membranous nephritis confirmed. 99% specificity, no biopsy is needed in a nephrotic patient with normal EGFR. Okay, what are the exceptions? Unusual clinical course, atypical serology, treatment resistance. Then I go for biopsy. Otherwise, PLA2 positive, straight away immunosuppression is the treatment. Histological scoring and guiding management. Oxford MEST-C score, NIH activity score. What is MEST? Mesangial hypercellularity, endocapillary hypercellularity, segmental glomerular sclerosis, tubular atrophy, and interstitial fibrosis. C is the crescent. It is called the MEST-C score. Utility predicts long-term renal survival independent of clinical features. Guide immunosuppression versus supportive care. Whereas NIH activity on the lupus nephritis, endocapillary hypercellularity, fibronoid necrosis, cellular crescent, hyaline thrombi drives aggressive immunosuppression. If it is chronic, no immunosuppression because already glomerular sclerosis, there is fibrotic crescent, tubular atrophy, drives only supportive care, cardiorenal protection, contraindicates immunosuppression. So, if you look at the NIH score, you get two classifications, two ways. One is an active case with reversibility, where immunosuppression you have to do, endocapillary hypercellularity, and fibrinoid necrosis in cellular case. Whereas, if you have chronic irreversible type, glomerulosclerosis, fibrous crescent, tubular atrophy, there is only supportive care, renal care, and contraindicates any further immunosuppression. Now, there is another thing added now. Advanced diagnostic techniques, mass spectrometry-based antigen discovery. On the slide, you use a spectrophotometer and spectrometry related. The problem is 20% of membranous nephropathy patients are double negative. That means they are negative for PLA-R and THSD7A also are negative. Then the solution, laser capture micro dissection of the glomeruli followed by peptide digestion and mass spectroscopy. It identifies the other antigens like NEL1 or exostosin 1 and 2. The point, another important thing is focus. What is focus? Point of care ultrasound. That means every patient must go ultrasound by bedside assessment of severe volume overload, edema and nephrotic spectrum, rapid evaluation of the kidney size, cortical echogenicity is maintained or not, and immediately estimate the disease chronicity before a biopsy is even scheduled. So, mass spectrometry and point of care ultrasound are two important additions. Now, this matrix will help you very clearly. This is called glomerulonephritis AC matrix. See, on the x-axis, you have the chronicity. On the y-axis, the immunological injury. So, if the immunological injury is more and the disease is less chronic or acute, then you are in the immunotherapy zone. Whereas the other way around, disease has moved into the chronicity, not much of immunological activity. The brown area, there you are supposed to use ROS blockade, SGLT inhibitors, BP control, salt restriction, avoid immunosuppression. Whereas in the blue part, action is high activity, urgent immunosuppression, steroid, rituximab, cyclophosphamide. If you are in the brown zone, no immunosuppression, protect the kidney, ROS blockade, SGLT2 inhibitor, BP control, salt restriction. The final insight is entire multi-level diagnostic strategy, lab, serology, biopsy, immunofluorescence exists solely to plot the patient precisely in the matrix. You must know how much is the amount of immunological activity, how much is the disease activity or chronicity. This is derived from low GFR without active sediment, shrinking kidney size, focus, tubular atrophy, and glomerular sclerosis. How do I say chronicity? There is low eGFR without active sediment in the urine. Kidney size is shrinking in the ultrasound. Tubular atrophy is noted. Glomerular sclerosis is demonstrated. Then I say the disease is chronic. Whereas immunological injury is active urinary sediment is there, RBC are there, dysmorphic RBC are there, proteinuria is there, raising autoantibodies titers are there, PLA2 antibodies and ANCA antibodies, cellular crescent, and hypercellularity. Okay. Glomerulonephritis clinical blueprint, management, prognosis, and future therapies. Earlier, what we used to do? Blunt immunosuppression. Give everybody immunosuppression. It is not like that now. Glucocorticoids, cyclophosphamide applied uniformly by proteinuria. If any patient of proteinuria is found out, we used to treat with steroid or any other immunosuppressive treatment previously. Now, it's not like that. Do a biomarker, do the histology, and stratify. If PLA2 are positive, targeted hemodynamic modification. MEST-C is positive, targeted immunological modification. ANCA is positive, targeted cellular modification. So the clinical blueprint scope is universal foundations, and also you have the KDIGO and the cellular pipeline. So how do I go about? There is one non-negotiable core. Every patient should get this. Then there is a new standard of care. Then the evolving care. What is the non-negotiable core? Maximally tolerated RAS inhibition. Either ACE inhibitor or ARB. Always you must try to give the maximally tolerated dose coupled with strict blood pressure control and select high risk populations less than 1. This is non-negotiable. Every patient of glomerulonephritis, maximally tolerated RAS inhibition plus strict blood pressure control to 130 by 180, or some patients less than 1. This everybody should get it. Then, what is the new extra standard of care I can add? SGLT2 inhibitors. Why? This subgroup of analysis from DAPA, CKD, and EMPA kidney trials demonstrated a substantial reduction in the progression to ESRD. Second line agents after the RAS. So, selected patients should get SGLT2 inhibition also. Now, what is the third level? Endothelin receptor antagonist like sparsentan and mineralocorticoid receptor antagonist like finerenone or the newer drugs. So, there are 3 levels. Everybody should get BP control, RAS inhibition maximum. Second one level is SGLT2 inhibition. Third level is add endothelin receptor antagonist, sparsentan or MR antagonist like finerenone. These are the 3 levels. Now you see IgA nephropathy, the first one. IgA nephropathy, GDIgA, that is glucose deficient immunoglobulin A nephropathy, quantifying the risk, treat to target. What are the things I do? I should do EGFR at biopsy, systolic BP, diastolic BP, proteinuria, age at biopsy, race, use of ACE inhibitor CRBs, MEST score, whether it is all 5 are there. That is 0 to 1, 1 to E score 0 to 1, like that. Immunosuppression use is already there. The output is it predicts the risk of 50% EGFR decline in the kidney failure. Then you have to treat to target endpoints. What I should do? Proteinuria should be controlled to less than 0.5 grams. Blood pressure less than 120. Urinary sediment should resolve. Renal trajectory stabilization of the EGFR. So proteinuria, blood pressure, urinary sediment, and then stabilizing the EGFR. These are the 4 mechanistic interventions. Hit 1. So, disrupting the 4-hit hypothesis of IgA nephritis. First, what we are saying is gut mucosa. There is a production of galactose deficient immunoglobulin A1. So, the immunoglobulin A1, IgA1 is produced. Budesonide and Nefecon targeted mucosal immunomodulation at the Peyer's patches of the intestine. This is the first hit at the level of the intestine. Second one is immune hit. This is an antibody production, BAFF and APRIL inhibitors. We have got 2 drugs now, sebiprilinemab and telitacicept. These are the two drugs. Hit 3, immune complex formation and complex activation. We have got copons, the eptacopon, and these are the different types of copons available. Finally, when you have got the mesangial deposition and inflammation, you have the dual inhibitor, endothelin inhibitor, sparsentan. So we are now having TRF budesonide, Nefecon is the first hit, that is at the gut level. Then BAF and APRIL inhibitors at the level of systemic immune injury, not on the kidney. Immune complexes formed, complement activation, iptacopan is the drug. Finally, on the glomerulus, there is mesangial deposition, you use sparsentan. Likewise, the treatment is no different. Low risk, moderate risk, high risk, very high. What is low risk? Normal EGFR, proteinuria is less, serum albumin is good, decrease of more than 50% after 6 months of conservative. Then, this is the wait and watch. Here there is no treatment for low risk people. And moderate risk people, normal EGFR, proteinuria more than 3.5, no decrease in the proteinuria over 50% after 6 months, conservative therapy. Here, rituximab, calcineurin inhibitors can be tried. Whereas in the high-risk patient, EGFR is already reduced, less than 60, and then the proteinuria is more, PLA2 receptor antibodies are present, other markers are present. You give rituximab, cyclophosphamide, glucocorticoids, calcineurin inhibitors, plus residue. Very high-risk patient, life-threatening nephrotic syndrome, then rapid deterioration of kidney function, not otherwise explained, cyclophosphamide and glucocorticoid. Depending on whether what is the risk category of the patient, you have to wait and watch or treat him with rituximab and see calcineurin inhibitors, or treat him with rituximab plus cyclophosphamide plus glucocorticoids, or calcineurin and rituximab, and finally very high risk cyclophosphamide and glucocorticoids. Now, this is a very important slide for you. You see the proteinuria curve, the green curve, it takes 12 months for the proteinuria to come down. As you can see here, the proteinuria curve is coming down, started coming down at 12 weeks, and slowly by 18 weeks to 12 months, and by 18 and 24 months, by 2 years, the proteinuria is disappearing. Whereas anti-PLR titers are falling within 3 months. What does that mean? If I monitor the PLR2 antibodies, serological remission can be picked up quite early before proteinuria-oriented remission. Disappearance of anti-PLA2R dictates therapy cessation. I know now that the patient is remitting and responding when the anti-PLR titers are coming down. In that case, what I will do, when the anti-PLR2s are coming down, then I can stop the treatment even though the proteinuria is continuing. I don't have to wait for the proteinuria to stop. This is a clinical change in the clinical perspective, navigating the immunological thing. Now what I do? Start the treatment at 6 months, you do the PLR. Okay. If the PLR is absent, then stop immunosuppression. PLR is continuing, persistent. If it is there, switch the therapy to calcineurin inhibitors or cyclophosphamide. Now, histological divergence, 3 and 4 and class 5. And NIH prognostic scoring is there, activity index of 0 to 24, chronicity index of 1 to 2. We have to differentiate active disease from chronic disease. What is active disease? Endocapillary hypercellularity, neutrophils, karyorrhexis, fibrinonecrosis, cellular disease. Active disease requires immunosuppression. Chronic disease, glomerular sclerosis, fibrosis, fibrotic recents are there, interstitial fibrosis, tubular atrophy, doesn't require immunotherapy. He only requires ROS inhibitor at the most, and probably add SGLT2 inhibitor. Now, triple therapy paradigm in active lupus nephritis. Somebody has got lupus nephritis. What are the drugs that we have? We have 2 trials going on, belimumab trial and then the voclosporin trial, Aurora data. Now, the Willis-Allen data, monoclonal antibody targeting BAF. This is B-cell, what is BAF? B-cell activating factor. B-cell activating factor is a monoclonal antibody which is produced. What is the drug we use? Belimumab. Efficacy, very efficacious. Clinical profile, best for gradual, sustained immunomodulation, prevents extrarenal flares and preserves the ovarian function. In which case, active nephritis, lupus type. So we are now dealing with lupus type. And the standard of care for lupus type is what? Mycophenolate mofetil plus steroid. You have to give MMF plus steroid is a lupus nephritis. That is standard of care. On top of that, you can add anti-BAF antibody drug, which is the belimumab. If you add belimumab, the response is better in 50% of it. Or you can use CNI inhibitors, calcineurin inhibitor, which is voclosporin, calcineurin inhibitor, that Aurora trial, faster reduction of the proteinuria via direct forward stabilization, rapid clinical response. Now, what is the treatment for active nephritis? Active lupus nephritis. Active lupus nephritis is mycophenolate mofetil plus glucocorticoid. Belimumab is an add-on drug. Voclosporin is also an add-on drug. Voclosporin is a CNI inhibitor. Belimumab is a BAWF receptor inhibitor. Okay. Now, this is ANCA vasculitis. Mandates for steroid minimization. ANCA vasculitis, you see, traditionally you give 1 milligram per kilogram body weight. Now, we are reducing the dose of steroid in ANCA vasculitis. Only 0.5 milligrams per kilogram plus rituximab we have to give. If you add rituximab, you can minimize the toxicity and reduce the steroid dose to half. Or you can use avacapon integration, targeted C5AR inhibition, replacing the high-dose systemic steroids. Now, today, ANCA vasculitis, steroid has to be given, but we want to minimize the steroid. How? Either I give them reduced dose of steroid, prednisolone, and combine with rituximab, or I give them avacapon, which is a C5AR inhibitor, and reduce the systemic toxicity. Avacapon, what is avacapon? Avacapon is a oral C5A receptor inhibitor, blocks the neutrophil chemoattraction and activation, and bypasses the upstream complement component, preserving the immunoprotective functions. Clinical role, used as an add-on to standard induction care to facilitate rapid aggressive tapering of the systemic glucocorticoids. Now, rituximab. What is the place of rituximab? Remission achieved. A patient had remission. Okay. And scheduled dosing is there. 500 milligrams of rituximab every 6 months for 8 to 424 months. Highly effective in preventing relapse. Guarantees prolonged B cell depletion, leading to hypogammaglobulinemia and cumulative infection. The problem with rituximab is it suppresses the B cell immunity. There will be hypogammaglobulinemia, cumulative infection. Now, when you do the biomarker guided treatment, rituximab, redosing only triggered by specific biomarkers. What are the biomarkers? CD19 B cell repopulation and or raising ANCA titers. Then I have to reintroduce the rituximab. Minimizes the cumulative drug exposure and infection risk. Very rigorous titering. Now, the diagnostic calculator, the 7-point check, this is also called the plasmic score for TMA. That is when schistocytes, thrombocytopenia, unexplained AKI appear in a patient with glomerulonephritis or SLE. 7-point checklist. What is the platelet count? Is there hemolysis? Is there reticulocyte count more? Is there any active cancer? No solid organ or stem cell transplant. MCV less than 90. International normalized ratio less than 1.5. Creatinine less than 0.5. If you have these things, the score is between 6 and 7. High risk for severe disease, and then you have to initiate treatment, therapeutic plasma exchange or PLEX. Plasma exchange transfusion. Whereas if the score is less than 4 or 4, low risk for thrombotic thrombocytopenic purpura, and consider complement mediated TMA and then alternative diagnosis and proceed to Sarada 5 minutes lo call chestanu. Okay. Now, this is related to the plasma score. Now, a refractory patient did not respond. What to do for him? Number one, is he taking the medicines properly? Verify adherence and hemodynamics. Are he actually taking the drug? Is BDP controlled? Maximize the ROS inhibition, add SGLT2 before escalating the immune suppression. First step is verify whether the patient is taking the drug. And is he getting ROS adequate inhibition and SGLT2 before adding on immunosuppression. Then immunological reassessment. Check the biomarkers. Is PLA2R positive, ANCA is positive, or dsDNA titers are rising. Rising titers indicate true immunological relapse requiring immunosuppressive treatment. 3. Shift the mechanism of action. If failing with immunosuppression steroid, go to CNI or rituximab. consider adding plasma exchange. And finally, if clinical deterioration is unexplained by serology, rebiopsy is mandatory to distinguish active inflammation from chronic scarring, which requires stopping the drug. If there is chronic scarring, you are not supposed to give immunosuppressive drug. Finally, pipeline. Next generation, what are the next generation drug available? April BAF axis. Immature B cell is there, and April BAF axis is sibeprenlimab and telitacicept. Sibeprenlimab, telitacicept, or povetacicept. Both are congeners. Upstream cessation, pathologic, pathognomonic GDA1A, that is galactose deficient A1A, and autoantibody production by starving the autoreactive B cells. Now, immature B cell has to mature into a plasma cell and produce your antibodies. Now, long-lived plasma cells, that is CD38 are there. You give the drug felzartamab, which is an anti-CD8 monoclonal antibody targeting mature plasma cells, and that clears the enhanced sources of the immunology. Now, ultimate frontier of cellular engineering in glomerulonephritis. Extraction. T cells are extracted from the patient's peripheral blood, and they are engineered using a viral vector, chimeric antigen receptor, CAR receptor to the T cells. Now CAR T cells are formed, that is engineered T cells are formed, and they are now injected into the patients. Now what they will do? They will hunt for the antibodies on the B cell and infusion of the CAR T cells to hunt the CD15 B cells deep in the renal tissue. This is called cellular engineering in glomerulonephritis. Key challenge, high toxicity profile, cytokinase release syndrome, neurotoxicity limits, concurrent use to life-threatening cases entirely refractory to conventional biologics. So these two slides are not already in vogue. One is the April inhibitors and the BAF inhibitors, and of course the long-lived plasma cell inhibitors. The second one is the T-cell engineering using the T-cell extraction. Then you engineer them with the viral vector and use them to hunt the B cells of the kidney. Okay. Now we have come to the IgA nephropathy, very common disease, immunoglobulin. What is the primary biomarker? Glucose deficient, galactose deficient, immunoglobulin A or MAST C. These are the biomarkers. What do I give? Sparsentan, Nefecon, Eptacopan. Target proteinuria should be less than 0.5, stable eGFR. Steroid sparing strategy, replacing the systemic steroid with the mucosal and complement target. Second one is membranous nephritis. Here PLA2, PLA8 phospholipid A2R receptor, rituximab, and then the calcineurin inhibitors. Immunologic remission is achieved, rituximab first line over cyclophosphamide steroid. Lupus type of disease, dsDNA, NIH score, belimumab, voclosporin are the two types of drug, and then the protein excretion ratio should be less than that. Triple therapy to lower cumulative glucocorticoid dose. ANCA vasculitis, it is from the red cells, MPO antigens, PR3 antigens, ANCA and BBAs, avacopan, rituximab are the targeted drugs. And low-VAS protocol, avacopan replacing drugs also are there. This is about the 4 different types of the clinical blueprint. The era of uniform immunosuppression is over. Earlier days, everybody we used to immunosuppress. It is not like that. First of all, we have to classify the disease, whether it is IgA nephropathy or PLA2 receptor problem or lupus nephropathy or ANCA vasculitis. Then only you have to try the treatment. So that's it. I think we stop here. There are a few other slides which I will share with you. This is about the pediatric and pregnant population, which may not be directly useful for you. Okay, stop here.